This was again, as I said, associated anomaly. Upper pouch is seen, you can only see two levels. Child had associated pyloric atresia. So therefore, esophageal atresia, pyloric atresia, no gas shadow beyond the pylorus. So therefore, be careful about this. You need to tackle both these problems, one after the other. Next. Of course, the management is basically conservative, stabilization, get the child ready for surgery. Next. Options for the surgical repair are either a primary repair where you do everything at one stage. That means once you go in through the chest, you identify the upper pouch, you identify the lower pouch, identify the fistula, disconnect the fistula, close the fistula, anastomose the upper to the lower esophagus, come out in one stage, end of the matter. Hopefully you have done the best for the child. Child should survive provided lungs and everything don't give up. Associated anomalies are not there. The other is delayed repair, where like diaphragmatics, you stabilize the child, get the lungs in better condition, then go in and do the surgery. Or do only part of the surgery where you go in, just ligate the fistula, come out. Stabilize the child and then go in and do the rest of the repair. So that is stage repair. Or of course, if there is pure atresia and there is a very large gap between the upper and the lower pouch, obviously you are not going to get it end to end. Then at a later stage, which is around 1 year, we do an esophageal replacement. Next. So this is the position of the child, left lateral position, you take the right thoracotomy. Next please. Some of these you may not be able to see properly, that is the azygos vein which we have to cut. So as, because just below that is where the esophageal part going into the trachea is seen. Next. We go ahead and ligate the fistula. Next please. And this is how it looks. This was where the fistula was opening into the trachea. This is now the disconnected. That is the upper pouch. And now we have to get the upper pouch and the lower pouch end-to-end anastomosis. Next. That is the upper pouch which you can barely see. Next. That is after the anastomosis. I'm sorry, you can't see anything. Post-op care, of course, is important many times because they have already aspirated either their own saliva or the feeds if it has been given. You need to keep on a ventilator for 2 to 3 days, maybe more. You may have to give parenteral hyperalimentation, watch the antibiotics, improve the lung condition, then gradually go off the feeds, then start anastomotic feeds, then remove the Ray's tube, start oral feeds, check for a leak, and then send the child home. Next. This was the child who was about to go home. The dressing is on the side of the intercostal tube. Next. Then there is of course delayed repair where you first do a gastrostomy. So you are taking away the fistula part. So now the stomach contents will not go into the trachea because you are doing a gastrostomy and decompressing. Then you go in through the chest, do whatever has to be done. Next. Next. Stage repair again, first you do just ligation with the gastrostomy, then stabilize, give alimentation, then go back and do the regular repair of end-to-end anastomosis. Next. These are alternative staging methods depending on what conditions you have, whether you have ventilators, whether you have good post-op care, whether you have the facilities. If you can do everything in one shot, nothing like it. If you cannot, yes, you need to do staging. Next. Of course, there are complications. Any surgery has complications, so therefore complications are part and parcel which we always look for post-operative. Next. Lastly, this esophageal replacement may have to be done when there is too big a gap, whether it is pure esophageal atresia or sometimes even with a tracheoesophageal fistula. If the distance between the upper pouch is anything at say T1 or C7 and the lower pouch usually is around T4, if the gap is very wide, there is no way you are going to get an end-to-end anastomosis, in which case you just do an esophagostomy and come out. And then later on at about 1 year of age, you use either the stomach pull-up or a part of the colon or part of the intestine. Next. This was the child who had pure esophageal atresia. Next. go through the neck, you identify the esophagus next. You pull it out. That is the upper pouch which we are bringing next. And then you make a stoma, so that now whatever he swallows by mistake, or even if you need saliva, etc., it comes out from here. It does not go and overflow and aspirate into the lungs. So do an esophagostomy and forget about this child for the next 1 year. And then only go in and do a full anastomosis. Gastrostomy. Gastrostomy with esophagostomy is done at the same time. Next. And then sometimes you use a tube made from the stomach, or in some cases now we are preferring to pull the whole stomach up as the esophagus and anastomose it into in the neck, push it down and then close the anastomosis. Next. Again, there are no paradoxes here. Early diagnosis is a better prognosis in case of TO fistula before they have the complications of aspiration, pneumonia, bronchopneumonia, etc. Early recognition followed by aggressive therapy of complications before surgery, following it up with proper intraoperative technique, with excellent post-operative care and management of a cardiac anomaly if associated simultaneously. Only thing is severity and type of associated anomalies may change your result, no matter how good a surgeon one may be. If there are associated anomalies, they are going to spoil the results and the type of surgery done next. So, if it is pure esophageal atresia, obviously there is no way you are going to get a primary repair. So what you do is just do a gastrostomy, upper pouch suction, stretching, etc. You may do, or do an esophagostomy and a gastrostomy. Come out, wait for the child to stabilize. At 1 year, do an esophageal replacement. Next. If you can do the stage procedure of trying to get the anastomosis at say 6 to 8 weeks, it would be ideal because you are using the child's own esophagus. The replacement of an esophagus is not or never going to be as good as the esophagus of the child himself or herself. So if you can, we try to use the child's own esophagus, you push from above, you pull from below, and try to get them together. If you can use their own esophagus without causing further damage, nothing like it. But if you think that is not going to be possible at all, then it would be worthwhile to do a staged repair with esophageal replacement. Next.
So what is the
Madelung deformity is the same thing, where you have this absence of radius. So there is a normal humerus and then there is no radius ulna, and straight you have the hand over there. So that's part of the limb anomaly, lateral, what I was saying, the L part. Next. GA reflux is very common post-operative after doing the surgery. Either because of the surgery, you may have damaged the vagus nerve. There may be abnormal esophageal peristalsis which is causing reflux. So therefore, we may need to undergo multiple surgeries. And that is what we need to emphasize to the parents, that yes, we are doing surgery, but this is not the end of the follow-up. It's not like I have done TO fistula, he has gone home, now everybody lives happily ever after. No, it does not. Next. Esophageal motor dysfunction, abnormal esophagus by itself will maybe enhance the gastroesophageal reflux, and if that is so, this is a type of a secondary gastroesophageal reflux, and secondary gastroesophageal reflux, the therapy would be surgical. Next. Delayed gastric emptying again can give rise to a lot of gastroesophageal reflux, and therefore you may need to do either a pyloroplasty associated with fundoplication. Next. And this is, I think, written by Willis Potts in 1950. The surgery of esophageal atresia with tracheoesophageal fistula is extremely delicate, and you may do a fine job, as it says, but if there are associated anomalies or bad lumps, your results can still get fired. Next. Thank you.